be a little bit easier because it's all about stuff that you've taken care of and you've managed over your career. So the way this goes tonight, because my voice goes in and out, sometimes I sound like I'm like an older man, I'm going to ask questions and have you come up with answers. So here we go. What is a clinical manifestation of Cushing's syndrome? Okay, what else? Hump, buffalo hump, moon face, buffalo hump. What else do they do? Stria in the abdomen. What else? I know I'm making you just rack your brains. We got obesity, bruising, yay! That's right, bruising. They get easy bruising. Okay. If a patient has Hashimoto's thyroiditis and they have a goiter, what clinical finding requires the most immediate action? Not the goiter. They have a goiter, they have Hashimoto's thyroiditis, but what's something that happens to them that needs to have immediate action? Controlling the heart rate is certainly important, but what's one more thing important than that? No, not replacing their thyroid. You're on the right track. They have dyspnea, so what do you need to fix related to their dyspnea? Increase their they have an increased PCO2, so you may want to work on decreasing that PCO2 so they're not so breathless. Very good. What's the definition of cardiac tamponade? Okay, yes, the heart is compressed so it doesn't squeeze effectively, but what kind of fluid is around that? Pericardial fluid, exactly right. So be sure it's pericardial fluid, and that fluid then compresses the heart and doesn't allow it to expand to get blood back and then to squeeze to get it out. Okie dokie. All right, what are the signs and symptoms of Addison's disease? Vitiligo, GI issues, weakness, hypoglycemia, can have weight loss, what about their blood pressure? Blood pressure is low. They often have hyperkalemia. What about their heart rate? The heart rate is often elevated. So they're hypotensive and tachycardic and hyperkalemic and hypoglycemic. Excellent. So when you draw a hemoglobin A1C, what kind of information are you obtaining? Exactly, the blood sugar levels over the last 3 to 4 months. And so it's an average of what that is. All right. So somebody presents and they have elevated anterior pituitary hormone. What lab result do you expect to see? Sure. You see a patient who has increased anterior pituitary hormones. What is one kind of lab result that you expect? I said it in a different way, but essentially the same thing. What else? What would you expect to find in the urine? Increased urinary cortisol. Very nice, Marlene. Okay, you have someone present to your clinic with a severe headache and acute confusion and a serum sodium level of 118. What diagnostic test do you think would be most valuable? I just gave you the sodium level, 118. Urine osmolality. What else? So where is the sodium? Low or high? It's low. So what can make you pee more or pee less? Diabetes insipidus, probably not. Lack of antidiuretic hormone. So that would be a good choice to draw a lab level because this guy looks like what? Is he fluid volume overloaded or fluid volume depleted? 118 is the sodium level. And you want to check an antidiuretic hormone. Most likely he's fluid volume depleted, which is because it causes headache and is acute confusion. Very good. What are the signs and symptoms of hypothyroidism? Lethargy, confusion, these are good. Constipation. Bradycardia, weight gain. Thin hair. And what about the texture of the hair? How does that change? It gets very coarse, exactly. What about your body temperature? Periorbital edema, excellent. Cold intolerance and your body temperature decreases. Boy, I can't trip you guys up at all. All right, at the 10-day post-myocardial infarction, at about 10 days, what is happening pathophysiologically with the heart? You have a scab. There's some healing. But tell me about the scab. Patient needs to rest. It's mushy. Absolutely. Sure. At day 10, tell me about what's happening post-myocardial infarction. And Marlene, you mean the scar or the scab can be torn? Amberly, yes. Collagen, you have a collagen, a mushy collagen matrix. The patient feels better. They think they can, go out and run a marathon. It's very fragile. It's very mushy. And there's an increased chance of developing an extension to your infarct. Great. If you have somebody come in to see you and they say, I can't get my shoes on at the end of the day, what would be some of your differential diagnosis? Heart failure. If they don't have CHF, what would be another diagnosis? Peripheral vascular disease. And of the peripheral vascular diseases, which one do you like? Chronic venous insufficiency. Excellent. Okay. Okie dokie. How about describe what happens in mitral valve regurgitation? Backflow. And where is that backflow? Okay, and what valve, I gave it away. Yes, the mitral valve doesn't close. It's the left ventricle. So blood flow backs up from the left ventricle into the left atrium. And during what phase of the cardiac event? Left ventricular systole. Excellent. If you had a patient come in and you thought that they were in DKA, what might you expect their pH to be? Down, because down is acidotic or low. What would you expect their bicarbonate to be? Right, a metabolic acidosis. Very good. Okay. There is a type of heart is caused by an autosomal dominant inheritance. What is that cardiomyopathy, and what are the pathophysiologic processes and clinical manifestations? Whew, what a big question. So we have somebody who has an inherited heart defect, it's autosomal dominant. What's the pathophysiologic processes and clinical manifestations? Hypertrophic obstructive, thickening of the septum. That is probably the most important piece. And what kind of a state does that push the heart into? Well, hyperdynamic, that's what I was looking for. Sometimes it's hard to get that, but you could have ventricular arrhythmias, but it's a hyperdynamic state. What is your diagnosis for someone who has pain in their lower extremities while walking, but that pain disappears after they rest? Claudication, right. It's peripheral artery disease, and they have intermittent claudication. Okay. What's one thing you want to make people with PAD and intermittent claudication do? They don't like it, but you want to make them do it. Walk, exercise, walk more, walk, right. Okay. All right, if you have an abdominal aortic aneurysm, it includes all three layers of the vessel wall. What kind of aneurysm is it? It's a true aneurysm, absolutely. You guys are ready. You are so ready. You don't need any more review. You're just going to rock and roll. Okay. Is dyslipidemia hereditary? True or false? True. Hyperlipidemia, dyslipidemia, all of that is genetic. You pass it on, you have to blame it on your family. So what are some signs and symptoms that we see in people who have dyslipidemia? Obesity is one. Coronary artery disease. Hypertension. And of course you have your elevated cholesterol, your LDL is not where you want it to be. I mean your HDL, and then your LDL is elevated, and your triglycerides are either elevated or just under the, right under the normal. Now, not everybody who has dyslipidemia is diabetic, but we often see the signs of glucose intolerance because they have a waist circumference greater than 34 inches. Okay. Mitral stenosis is often caused by what disease? Rheumatic fever. Exactly. Extensive clotting consumes clotting factors and platelets, leading to hemorrhage. What disease is that a definition of? DIC. Exactly. disseminated in intravascular coagulation. Okay, one of the things that we measure in patients with chronic hypertension is their urine. What are we looking for? Microalbumin. We're looking for protein in the urine. Protein is a rather big molecule, and the kidneys don't have a portal for that protein to go through unless there has been kidney damage that has occurred over time. So if somebody's having microalbumin and they have hypertension, then most likely their hypertension has not been well controlled and they've developed kidney problems. Microalbumin also shows up in diabetes, because when we have diabetes, then we have, again, damage to the kidney, and then we can have that protein can get through and end up in the urine. What is one of the very frequent complications of poorly managed diabetes mellitus 2? Alright, what else? Neuropathies is the answer. So, alright. What are some of the clinical signs and symptoms of right-sided heart failure? JVD, very good. Shortness of breath, edema, weight gain, increased heart rate, murmurs, weight gain, fatigue. What other organ? Liver. You can get hepatomegalia. Okay. Describe the physiologic mechanism that results from post-hemorrhagic anemia. Describe the physiologic mechanisms that results from post-hemorrhagic anemia. Well, we know we've got acute blood loss, but what is the physiologic mechanism? You have an increase in what? Not erythrocytes. You have immature cells, which is true. Which ones? Reticulocytes, absolutely. So you get increased reticulocyte production, and that happens because of what? Low oxygen. Absolutely correct. So the physiologic mechanism is an increased reticulocyte production in response to decreased tissue oxygenation. Yay! What does a shift to the left mean? There's more immature cells. It's usually seen in infections. Yes, more things on the left-hand side. And what is one of the physical signs and symptoms that you'll see? Fever, absolutely. absolutely correct. You see a new patient who has Hodgkin's lymphoma. When you do his exam, what do you expect to find? Enlarged lymph nodes. That was easy. Are those lymph nodes tender or painless? Painless, absolutely correct. So when a patient develops heparin-induced thrombocytopenia, what lab result shows a decreased value? Platelets. Absolutely correct. Very good. Okay, let's see here. What is a test we use in determining if someone has heart failure? A BNP, correct. All right, when a patient has a pituitary adenoma, why can it also cause thyroid and adrenal hypofunction? Pressure pushing on the rest of the cells. Excellent. So we all know that patients with diabetes have microvascular complications. What happens pathophysiologically to cause the microvascular complications? Thickening of the basement membrane. Excellent, excellent. And what does that cause? Well, and then what else? You get some poor tissue perfusion, but what happens to the surrounding endothelial cells? Hyperplasia. Very good. So what hemoglobin would make you concerned that someone might have anemia? Less than 7 would give me a lot of concern. Yeah, less than 12 in males, less than 15 in females. That's fine. If it's down around 7, you're in a bad way. Yeah, most of us do, because we don't eat right, especially if y'all are, not eating right and going to school and doing that. What is a sign of SIADH? Angela, do you live in the country on a farm? Eat more red meat. Decreased serum sodium, hyponatremia. That's a sign that would be indicative of SIADH. What is a sign of diabetes insipidus? I like it. Peeing, lots of peeing. It's increased serum osmolality. aplastic anemia. Increased iron levels, spleen enlargement, liver enlargement, bronze skin, and one more important one. No, cardiac arrhythmias, or cardiac dysrhythmias, however you want to say it. Okay. What hormone imbalance slows the rate of parathyroid hormone secretion? Hypercalcemia. Exactly. What naturally occurring chemical in the in the body can shorten the conduction time of the action potential through the AV node? Sure. What naturally occurring hormone in the body can shorten the conduction time of the action potential through the AV node? No. We want to shorten the conduction time, and if I shorten the conduction time, what do I do to the impulse? It's not up and I speed it up, okay? What is a naturally occurring hormone that can speed up your conduction through your AV node, through the AV node? Not adrenaline, not epinephrine, starts with a C, catecholamines, absolutely. What hormone is responsible for causing hypertrophy associated with hypertension? But Marlene, it was a good guess. All right, what is the hormone responsible for hypertrophy of the myocardium in the face of hypertension? No guess for you. Angiotensin 2. Great, Melissa. That was great. How does hypertension affect the kidney's glomerula? It causes them to break down, and what is the effect? Not constriction, but starts with an I. Not vasodilatation, but ischemia, absolutely. Okay, that hypertension reduces the blood flow to the area. Okay. Somebody trace the electrical activity through the heart. Yes. SA, AV node, down the bundle, then the right and left bundle branches, the Purkinje fibers, and the myocardium. All right, that's good. If somebody has a STEMI, what do you expect to see on their EKG? ST segment elevation, exactly. And if it's a non-STEMI, what do we see? ST segment depression, exactly. Oh. All right, you guys are pretty awesome. Now, you ask me questions, or ask me what you might have questions about, or you need something clarified. Yes, ST segment depression, T-wave inversion. So, how are you feeling about this exam? Pretty good? Obesity question on the test? I don't know. I can't tell you what's on the test and what's not. Nice try, though. You don't have the new book. Oh. Well, you need to know what kind of problems obesity causes. Diabetes, heart failure, hypertension, that kind of stuff. But not all the fine, infinite details about obesity. No, this is not pharmacology. You don't need to know the meds. That's in your pharmacology class. Prolactin, okay. Well, volume depletion will give you a headache. Confusion you can get. If your sodium level is really off the wall and very high, you can also get similar symptoms. But you didn't have enough lab values to determine, if the sodium was like 105, then you'd know they were fluid volume overloaded because they had a dilutional sodium. Okay, so you want to talk about prolactin and hyperpituitaryism. Okay, we can do that. All right. Where is prolactin produced? Yes, diabetes mellitus is an autoimmune disease. All right, let's look at prolactin and those pieces of information. Oh, come here. Okay, so hyperpituitaryism is caused by a slow tumor that grows in the anterior pituitary. Okay, that tissue secretes that hormone. So pituitary hormone that's secreted because that's where the tumor is. Pressure by that tumor on the surrounding areas causes decreased functioning of the anterior pituitary cells. So hypersecretion of prolactin are one type of cell that comes from the pituitary. There's tumors that secrete prolactin, and they're called prolactinomias. Okay? And they're the most common hormonally active pituitary adenoma. So there are other things that can elevate your prolactin level in the absence of a suspected pituitary problem. Renal failure, polycystic ovary disease, breast stimulation. It's a tonic and inhibitory hypothalamic control. So medications that block the effects of dopamine can increase prolactin production. Some antipsychotics like risperidone and chlorpromazine, metoclopramide, triglyceride antidepressants, and methyl-dopa are all medications that block the effects of dopamine. So the hallmark of having a prolactinomia is an increased serum prolactin concentration. So it's how much that tumor is producing the prolactin hormone. So if you have a high prolactin level, then you suspect that you have hyperpituitarism. Now, there's no feedback mechanism because that stuff is, the prolactin is just being rapidly produced. So, does that answer your question? Okay, pulsus paradoxus is simply the change in your pulse depending on if you're breathing, and it's associated with your breathing. You don't remember that from basic nursing? So it's really just a increase and decrease that goes with your breathing. Okay, what other questions? Now, you guys, I can't tell you if that's covered in the test or not. Autonomic neuropathy is generally seen from microvascular disease complications. You guys are just too funny. My favorite line is, "This is graduate school. Do you want me to give you the test so you can take it home?" You know, when I was teaching, not online, but in the classroom, I used to give a take-home test, and it took people 5 hours to take it. Okay, CRH and ACTH. Is there a feedback loop? No, just don't want to go overboard and then not focus on other items. You'll be fine. So, all right. So right this minute, CRH is, I'm trying to think, what is CRH? ACTH, all this stuff is on a feedback loop because the hormones are produced in the brain, they're sent out to the organ, organ produces what it's supposed to, because it's usually a stimulating hormone, and then it goes back to the brain and says, too much, not enough, cut it down, stop. So all of these hormones are on a feedback mechanism. That's how they're able to produce. Okay? Now, in Addison's disease, you get the elevated ACTH. Because you have low corticosteroid and mineral corticosynthesis. So that is sent back, and then the serum ACTH is then elevated. Now, in Cushing's disease, the normal diurnal or circadian secretion patterns of ACTH and cortisol don't exist. And normally, you would increase your ACTH or your cortisol in response to a stress. But in Cushing's disease, the increase does not take place. All right, anything else? Sorry, I yawned. Long day. I'm sure your days are longer. Okay, well then, you guys will do fine. I'll post this as soon as it goes through its malarkey it has to go through. And the exam is on Thursday, starting at 1 minute after midnight and ending at 11:59. You guys are going to do fine, not to worry. All right, good night.